Okay, it's officially 1 o'clock Eastern Standard Time. Of course, that's noon Central Standard Time. So that is our start time. Let's go ahead and get going. So welcome everyone to our free Wednesday webinar. Today we are going to be talking about labor and delivery. And we're not just going to do boring slides or anything like that. We're going to follow a patient through a case study, which I think is far more interesting. Definitely be ready to learn a lot about labor and delivery today. Now, for those of you who don't know me, my name is Elizabeth Diger. I'm a women's health nurse practitioner. I've practiced in an OB/GYN setting for about 10 years. And prior to that, I was actually a critical care nurse. I worked in ICUs and ERs. So I'm really excited today to share my passion with you, labor and delivery. So that being said, before we get started, where is everyone joining from? Go ahead and feel free to join Slido. You can go to slido.com. You can also use this QR code to take part in the survey. So you can also put your answers in the question box. By the way, for any of you guys who do have questions during today's lecture, please feel free to ask those. We have the wonderful Rachel Taylor on today. She'll be covering all of the questions. Oh, great. We have some people outside of the US, which is cool. What about the rest of you? Oh, Kenya, again, Canada. How awesome is that? Let's see, let a couple more people answer here. Los Angeles, oh, I'm jealous. I bet it's nicer there than it is here in Michigan, where it's starting to look a little bit like winter. Very cool. Saudi Arabia, New York, Germany, the UK, Florida. That's amazing. A lot of people from Florida. Well, welcome all of you. I'm very excited to have you for this presentation. That being said, let's get to know our client. Like I said, we're going to be following our client through a case study. And today we're going to meet Anna Smithton. She's a 29-year-old female and a first-time mom, and she's at 37 weeks plus 6 days gestation. She calls her OB provider and states, "I'm having scant bleeding about 24 hours ago, and I think I may be in labor. Should I come in?" The provider asks a very important question. They say, "How many pads have you bled through in the last hour? Do you have any pain?" And Mrs. Smithton says, "I've changed my pad 3 hours ago. I don't really have pain, just some vaginal pressure and some discomfort in the lower back." Provider, yeah, this is what I would say too. I would like you to come in as soon as possible so we can monitor you and baby a little bit closer. So absolutely, the patient was right to call in because she's having some symptoms of labor. So let's talk about how do we determine if someone is in labor or not. And one of the first ways we do that is to assess the contractions. Now, Mrs. Smithton didn't really talk about her contractions, but I'm sure we're going to ask about them when she comes in. And there are true labor contractions. These are contractions that do lead to true labor. They cause dilation and effacement of the cervix, versus false labor contractions really don't cause the progression of labor. These are also known as Braxton-Hicks contractions. So let's compare these. In true labor, the contractions are going to be regular. You can time them with a stopwatch, and the interval gets closer and closer and shorter. With false labor, they're irregular. You can't time them with a stopwatch, and they do not get closer together. They're just all over the place. For true labor, regardless of whether the mother moves or rests or or does anything really, the contractions are going to just keep happening no matter what. Whereas for false labor, they maybe stop if you rest or you get up and move or you change positions. One of the first things I do when a patient calls and I'm suspicious if they're maybe having true labor contractions versus Braxton Hicks is I say, I want you to empty your bladder. A full bladder can cause false contractions. I want you to drink a full glass of water. Hydration helps calm down false labor. And I want you to rest for 15 minutes. If the contractions go away, it wasn't true labor. If they do go or don't go away, then we're thinking probably we have true labor. Also with true labor, the intensity of the contractions is going to get stronger and stronger and stronger and more painful, whereas with false labor, they're pretty weak and irregular. And then finally, for true labor, for many women, they're going to start in the lower back, which is something Mrs. Smith then mentioned, and they're going to radiate into the front of the abdomen versus with false labor, typically they're just in the front, they're not too strong, and again, they're very irregular. But really, one of the things I tell my patients is to watch for the 5-1-1 rule. This means if you're having a contraction every 5 minutes, the contractions are lasting for a full minute, and that happens consistently over an hour, you are definitely in true labor and you need to get down to the hospital because you're going to deliver soon. Another way we determine if someone is truly in labor is to assess for the amniotic sac rupture. Now, this can occur when a woman is actively in labor, when she's actively contracting, but it can also occur before she starts laboring or contracting. Typically, though, if the rupture happens first, usually contractions will soon follow. Rarely there's a gush of fluid in all the movies and TV shows. It's always this big dramatic, oh no, I broke my bag of waters, and there's a big gush. In the real world, that happens very rarely. Typically, in most occasions, the rupture will be just a little pop, and then there's just a steady trickle of fluid that comes out after that. Some acronyms that you should be aware of are one of the first ones is PROM. That stands for premature rupture of the membranes. And this essentially means that the amniotic sac ruptured before contractions or labor began. And again, that can happen normally. If that happens, one of the best ways to accurately tell if the amniotic sac did rupture is we do something called a nitrazine test. It's a pH test that assesses if we really have amniotic fluid or not. PPROM is a preterm premature rupture of the membranes, and this is when the water breaks before 37 weeks of pregnancy. Remember, 37 weeks is term. That's when the baby is fully developed. 40 weeks is full term. So if someone has their bag of water rupture before 37 weeks, that is considered preterm. And this is often due to something bad going on. Maybe there's an infection in the uterus, something like chlamydia or gonorrhea can cause this. We also see this more commonly in women of lower socioeconomic status because they tend to receive less care in general and therefore are at higher risk for this condition. Finally, cigarette smoking can absolutely cause PPROM. And if that bag of water sits open for a prolonged amount of time, this can also lead to uterine and newborn infections. So you got to watch these people really closely. Finally, we have AROM. That's the artificial rupture of membranes, and that procedure is known as an amniotomy. This is also known as the breaking the water. The provider basically intentionally ruptures the membranes as a way to induce labor, and this has been performed by OB providers for hundreds of years. We've known this works for a while now, and basically we use a tool called an amni hook. Kind of just looks like a crochet hook, and we just hook that into the membranes, give it a little tug, and that opens up the bag of waters. And again, in most cases, that will help induce labor. Finally, there are some other signs you need to be aware of. If someone has bloody show, which again, Anna Smith then did mention she was having a little bleeding, that can be an indicator that the cervix is starting to dilate and thin out. A little bit of blood is an indicator of labor. On the other hand, if there's gushing large amounts of blood, that's not normal. That person needs to go into the hospital emergently. The mucus plug can be lost. Now, that's not a specific sign of labor, but we do see this as you're getting closer to labor. Basically, as that cervix dilates and opens up, you can lose that little mucus plug that was in that canal, and that's a sign probably you're going to go into labor in the next couple weeks. Back pain, especially lower back pain, is a very common symptom that we see in true labor, and Anna Smith then mentioned that. And you can also have nausea and vomiting because of the hormonal changes that occur during labor. But ultimately, it's really up to the provider to determine when a patient is in labor. The gold standard is to perform a cervical check, as contractions that lead to cervical dilation, that's the true definition of true labor. All right, I want to take a brief little pause here to talk about private tutoring. For any of you guys who are struggling to study for the NCLEX, if you have specific topics or concepts where you're like, oh, I'm just not getting this, this isn't making sense, something you might want to look into is our wonderful private tutoring program. This is really a one-on-one meeting where you get individual resources and feedback just for you from one of our expert tutors. And as you can see, there are a lot of us, so you'll definitely have a lot of great people to choose from. If you're interested in that, you'll just want to scan this QR code to book, and that's going to be $75 for 1 hour. But let's get back to Mrs. Smith then. It looks like she's arriving at the labor and delivery unit for further evaluation. And this is her medical chart. Let's go ahead and start with the history of present illness. So at 2100, Mrs. Smith then presents today with scant bleeding and concerns of decreased fetal movement. That's something we didn't hear before. That's important. If there's decreased movement, there might be something wrong with the fetus. Mrs. Smith then is 37 weeks pregnant and was told by her provider to come in for further monitoring. Mrs. Smith then only had one ultrasound at 10 weeks gestation. What do you guys think? Is it normal only to have one ultrasound at 10 weeks? Or was something missed in Mrs. Smith's care? Put that in the question area if you have an answer. What do you guys think? Exactly, Minkal. Very, very good. Yes, we want that 20-week ultrasound. Something was missed in her care. She should be having an ultrasound around 20 weeks gestation for the anatomy scan. So some things were missed there. Let's look at her physical exam. 2115. Upon assessment, Anna appears anxious and states that she is concerned about her baby. She reports that she had bled through one pad in the last 2 hours, and the blood is bright red, and that her bleeding has increased since calling the provider. Anna is hooked up to fetal monitoring, and a vaginal exam is deferred at this time. That is the appropriate thing to do. If someone is vaginally bleeding and they're pregnant, don't do a vaginal exam. It's not safe. And her vitals overall look good. She's got normal blood pressure, a touch high, but if she's uncomfortable, that would be explained. Slightly high pulse. Respiratory are 24, and she's at 94% on room air. So we hooked her up to a fetal monitor, and this is what we're seeing. Of course, on the bottom, we're seeing the uterine contractions. It looks like they're happening pretty regularly. So that makes me think she probably is in labor. And this is the fetal heart rate response. So take a peek at that. What do you guys think? Was that good or bad? That fetal heart rate monitoring we just saw. What do you think that looked like? Should we be worried, or is this actually reassuring? I would say I agree with you guys so far in the poll. I think that actually is a good thing. Yeah. Yeah, it's actually good because what we're seeing here is rises in the fetal heart rate. When the fetal heart rate goes up, that's an acceleration. And remember, accelerations are always good. That tells us when a stressor happens to that fetus, like a contraction, a contraction is going to squeeze that fetus and put them under stress. They should rise to the occasion. Their heart rate should rise to accommodate that stressor. So accelerations are good, and it's a nice 15 by 15 acceleration. What that means is the acceleration is going above the baseline heart rate by at least 15 beats per minute, and it's lasting for at least 15 seconds. That's a good quality acceleration. So we're a little worried about placenta previa here. The bleeding is picked up. What should we do to rule out placenta previa? What are we going to do just right away if we're suspecting this? Good. I completely agree with you. Yeah, we're going to do an ultrasound. Very, very good. Yeah, Minkal, very, very good. Yeah, because remember, she's having some major symptoms of placenta previa. She's having painless bleeding. Placenta previa is painless. There's bleeding without the pain. And it's bright red because that bleeding is happening right at that vaginal opening. So it's nice and fresh. And the fact that it's painless and bright red is important because that really differentiates that from placental abruption. Placental abruption, remember, is where the placenta tears away from the uterine wall. That condition, on the other hand, is extremely painful, and also you tend to have a darker red bleeding. But yeah, if someone called the office and said, yep, I'm bleeding, it's painless, I'm pregnant, one of the first things I'm going to ask them is, how many pads are you going through? How saturated are they? Are you having clots? Big clots are typically concerning. And we also, again, want to know the color. And pretty quickly after we ask that question, we're going to do an ultrasound, and that's going to tell us, is that placenta covering the cervix? Is it completely covering it, or is it only partially covering it? Certainly a complete placenta previa is often more concerning. So we did that ultrasound, and phew, the provider confirmed there's no placenta previa present. We did a cervical check, and guess what's happening? Mrs. Smith then is 5 centimeters dilated, and she's 80% effaced. She's actually in labor. So how do we assess those cervical changes? Well, like I said, you got to assess for dilation. If the cervix is dilating, that's an indicator they're actually in true labor. And remember, the cervix has to grow all the way from 0 to 10 centimeters to be able to allow that baby's big head to fit through that cervical canal. And basically the way we measure this is with our fingers. If I can only fit a little fingertip in, that's typically about 1 centimeter. If I can fit in 2 fingers, that's about 3, and so on and so forth. And with lots of experience and practice, you get really good at determining, okay, my fingers were this far apart, that's got to be about 7 centimeters. You get good at measuring that with practice. We're also going to measure effacement. As the cervix dilates, it's also going to thin out. And this is measured in percentages with the help of our finger again. If the cervix is thick and we can fit that cervix all the way, that finger all the way into the cervix to that second knuckle, that's a long, thick cervix. They're 0% effaced. They're not thinned down at all. If we can fit our finger in only to this first knuckle, they're probably about halfway effaced, 50% effaced. And if we can only fit our fingertip in, well, guess what? They're 100% effaced, and they're probably going to start pushing pretty soon if they're also dilated. So our client is currently dilating and effacing. They're going through that process. What stage of labor is our client in? Remember, there are 4 stages. What stage is our client in right now? Got a couple people logging in some answers. What do you guys think? I see someone's been studying the stages. Good. Getting some varying answers. I agree. I think we are in that very, very first stage of labor, and we're probably still in the latent phase. So remember, the first stage begins when labor starts. The contractions are starting and they're beginning to cause cervical dilation. And the first stage ends when the cervix is fully dilated to 10 centimeters. When that cervix is fully dilated to 10 centimeters, then the patient is going to move into stage 2, which is the pushing stage. That's where the baby is delivered. And remember, the first stage is really divided into 2 phases, the latent and the active phase. And right now, our patient is in the latent phase. This is when the cervix dilates from 0 to 6 centimeters, and it's going to be a lot slower. It's very unpredictable. So a lot of times when patients are still in that latent phase, we might even let them stay home and just kind of labor on their own a little bit. However, when they move into the active phase, this is when dilation is going from 6 to 10 centimeters. This really gets a lot faster. It's much more predictable in terms of the rate of cervical changes. So once they're in this active phase, we want them to stay in the hospital so we can monitor them and get ready for delivery. Now, if the client has no cervical dilation for 4 hours or greater, despite contractions looking like they're good, that indicates an arrest of labor. And basically, if there's an arrest of labor, that means the provider needs to have a conversation with our patient. You know, maybe we need to use medications to induce labor. Maybe we need to do a C-section instead, especially if the fetus is not tolerating labor, then we would push for that C-section a little bit harder. So Mrs. Smithton, yep, we sure did. We admitted her to the labor and delivery unit. She certainly looks like she's in labor to me. And we're going to put her fetus on continuous fetal monitoring. And we're also going to consider that birth plan. We need to know, okay, what does our client want for pain intervention? Who do they want in the room with them? You know, maybe they have a couple support people they want in the room. And when we ask these questions, Mrs. Smithton, she's not too sure about her pain management options. So let's talk about those next. But first, for any of you guys who are not already a member of Archer and you're kind of wondering, well, I'm interested in Archer, but I really don't know what package to get because there's a lot to choose from. Definitely our #1 recommended package is going to be the SurePass combo. You get a lot of bang for your buck with that package. It includes all of our on-demand videos. I think there's over 40 now, and a lot of them are very long, good videos. We have a huge Qbank with lots and lots of questions that are very close to what you're going to see on the NCLEX. And then you also are able to join our November live review, which is going to be in the first week of November. That's a 3-day live review that covers really the vast majority of what's most likely to show up on your test. So if you need a really fast review, if you need to get ready for your NCLEX quickly, that is the way to go. And remember, if you're an RN, you want to use the left QR code. If you're an LPN, you want to sign up over here. But what pain management options do you think we should teach our client about? What type of pain management options would you be telling Mrs. Smithton about? There's a lot of options. Minkal, I like those. I like those a lot. Yeah, the epidural is probably one of our most painful pain control options. I was a fan of mine. They work quite nicely, and we'll talk about those in a minute. But someone else mentioned, a couple of you now have mentioned, good job, Mandeep, those deep breathing techniques. There are also non-invasive, non-pharmacological techniques that work very, very well. And we're going to be talking about those first, but I real quick want to see, yeah, a lot of you guys are agreeing. I agree that epidural is going to be popular. So there are a lot of natural methods we can incorporate. One of the first ones is hypnobirthing. This is a technique that uses deep relaxation and hypnosis to actually decrease anxiety, fear, and pain. Now, can you just show up and do hypnobirthing? No, you need to practice this ahead of time. There are classes you can take to learn these techniques. Hydrotherapy is also very effective. Research has consistently shown that laboring in water really increases relaxation and comfort while decreasing pain and anxiety. Now, in the hospital setting, this is only allowed before the bag of waters have ruptured. We don't allow it afterwards because of infection risk. But oftentimes, if you do a home birth or if you do a birth at a birthing center, you can actually deliver in a tub, which is an option, but an option that does come with risks. Touch therapy can be helpful, but remember, women vary quite, as do all people, vary quite a bit on the amount and type of touch that's considered helpful versus a little bit uncomfortable. So you always want to ask, hey, do you mind if I hold your hand during this contraction? Or would you like if I rubbed your back a little bit? That can be potentially very, very helpful. Movement is also helpful. This helps the uterus to work more efficiently during labor and it decreases pain. So getting up and walking if you're not actively pushing is a good idea. Positioning is also important. Frequent repositioning really helps the pain with pain reduction. And there are actually tools called birthing balls that you can sit on, kind of bouncing, and you can rotate your hips and swivel your hips. And again, that really allows those muscles to relax. And then finally, like you guys said, deep breathing, that thoughtful deep breathing, not only provides a distraction from the pain, but it really reduces anxiety. And believe it or not, by taking deep, effective breaths, that's going to bring more oxygen to your uterus and it's going to help the contractions be more efficient and effective. Another minimally invasive option for pain control is nitrous oxide. This was first made popular in Europe and Australia, and this is becoming really, really popular in the US now as well because of how minimally invasive it is. It's a tasteless, odorless gas that's mixed with oxygen, and you don't just wear the mask the whole time. No, the mother actually holds the mask and takes a nice deep breath whenever she feels like she needs one. It's typically most effective, though, if the mother takes a deep breath about 30 seconds before the onset of a contraction. So that's where we come in. We're going to kind of coach that patient. Okay, here comes that contraction. I want you to take a deep breath right now. And it helps reduce anxiety. It gives you kind of that floaty, nice feeling of well-being. And what's nice is it does not limit movement for the patient. It does not slow labor, nor does it cause any significant risk to the baby. So it's very, very safe. Really, the main side effects, which by the way are rare, are going to be dizziness, maybe a little lightheadedness, which is kind of the point, but you might also have a little nausea and vomiting, but those symptoms typically resolve quite quickly. We also use systemic analgesics. These are going to lessen the pain without any loss of feeling or muscle movement. And typically we're going to use opioids given through the IV. So some typical examples we might use are meperidine or Demerol. Now that one's kind of going the way of the dodo. We're not seeing that much anymore. It's being restricted in a lot of hospitals, at least in the US, because of safety issues. But we still do use Stadol and Nubane and morphine quite a bit. And these are going to take the edge off, but really the bulk of of the pain will still be there. Now, they also present a safety risk because these are going to cross the placental barrier, so limited use is better as it can lead to respiratory depression in both the mother and baby, although if you dose this carefully and at the right times, these risks are very, very low. I will say though, some hospitals do limit use about an hour prior to the expected delivery. That way we're going to lessen sedation in the newborn, and that newborn's going to breathe and breastfeed better if they're less sedated. Local anesthetics are definitely used in deliveries. This, of course, is a method that's often used if we may need to make an incision in that vaginal opening. That's known as an episiotomy, or if we need to repair a tear or a laceration that occurred during delivery. And this, of course, is just a localized injection. It's going to very quickly numb a specific area without really any major negative effects to the mother or baby. But remember, this is just for localized pain. This isn't going to do a darn thing to relieve pain from those contractions. So typically women use this and other forms of pain control. And by far, one of the most popular forms of pain control is one of our regional anesthetics, the epidural. Now, a lot of people mistakenly think that the epidural is just a quick injection into the spine. No, it's actually a catheter. It's a very teeny catheter that's placed into that lower spine, and it's going to slowly pump pain medication into that area on a continuous basis. That pain medication is actually going to stop pain signals from traveling up the spine to the brain, so it blocks the pain. It removes almost all of the pain, or sometimes all of it, without slowing labor much at all. The mother's awake, alert, they're still able to, usually if it's done well, they're still able to feel pressure and contractions, and they should know when to push. The downside with these, they don't always work. If it gets misplaced, she might have just partial or sometimes no pain relief if that catheter wasn't placed correctly. And it does come with major risks. The major risk or adverse effect that you want to watch for is it can cause sudden severe hypotension. So if someone has hypotension, that can affect placental perfusion, and you can start to see those late decelerations. So watch for that closely. And remember too, many women with an epidural, they can't walk, they can't move their lower extremities. So sometimes we're going to place a Foley catheter in the bladder if the labor is going long. Now, most common side effects with this are going to be back soreness and itching, usually mild and manageable, but the one other side effect you got to watch for is a spinal headache. This is just a horrible, horrible headache that can occur after this procedure, and it happens when the membrane that surrounds the spinal cord is accidentally punctured during that epidural placement. And that's actually called a dural puncture, which causes spinal fluid to leak. And typically about 1 to 2 days after the epidural is placed, you start to get this raging headache, and it can last for 1 to 7 days. So typically first, if you're having this horrible headache, we're going to try the normal things: rest, hydration, oral pain meds. But second line therapy is an epidural blood patch. This involves actually injecting and inserting a small amount of blood into that epidural space, and that creates a patch where that leakage is to stop the leakage. And that usually does the trick about 90% of the time. It works really well. Similarly, we have another regional anesthetic called the spinal block, and this one is just an injection into that spinal space. It's typically used for pain control, especially during a planned C-section. And again, this is directly injected into the fluid of the spinal cord, and it blocks pain really, really effectively for a couple hours. What's nice about this is it takes effect really quickly, so you can also use it if they're about to have a painful procedure during a vaginal exam, like a vacuum assist or something like that. And this is completely going to remove pain from the lower body again for a couple hours. But remember, similar to the epidural, it can lead to a dramatic drop in blood pressure because that would lead to a drop in fetal heart rate as well. And remember, the common side effects are itching and back soreness, but you can get that horrible spinal headache with this one as well. And then finally, we have general anesthesia. Certainly, this is, used for those emergencies. We don't preferentially use this, but if someone needs an emergency surgery, we're going to put them under general anesthesia if we need to. We might also use this if we can't, for some reason, do a spinal or epidural. Maybe if someone had a really bad spinal injury and they need to be numb below the waist. And this is going to cause, of course, a complete loss of sensation and consciousness. And it's not ideal because it's really going to delay how quickly the mother can bond with her baby. Tends to really impact breastfeeding because of that. And there are a lot of risks with this method. You can see pneumonia and lung infections in the mother if they couldn't place the ETT tube well. There can be medication toxicity from the anesthetics. You can see respiratory depression in the newborn and fetal lethargy. And just generally, both mother and baby are going to have to stay in the hospital longer, which is not what we prefer. All right, quick pause again. Something else I just want you guys to be aware of if you're looking for more help with any specific topics is small group tutoring. This is a really cost-effective way to learn a lot about a lot. These are $25 for an hour, and you're going to have up to 15 students in a class, and it will be taught by one of us tutors. And we do a variety of subjects. The 2-hour NCLEX review is a popular one. We have mock NCLEXs, pretend NCLEX exams. We have sessions on pharmacology, which are good, cardiac review, you name it. So definitely check these out if you're needing any help on specific topics. But Mrs. Smith then, well, she's choosing her epidural, and about 30 minutes after the epidural, the client states, uh-oh, she feels something between her legs, and the fetal monitoring shows this. Take a peek at this, really analyze it. We're seeing our contractions down here. And above, we're seeing some pretty dramatic changes here to that fetal heart rate. Seeing some sharp drop-offs. Okay. What complication are we seeing? What's going on with that fetal heart rate monitoring? Does anyone know what we saw just now? That's probably, yes, that's probably what's going on. Yes, exactly. Let's see, who was that? Minkal, yes, exactly, Mandeep. Yeah, you are on the right track. Now, do you guys know what kind of deceleration is this? What kind of deceleration did we just see? That's where it gets tricky. Remember, there are early, late, and variable decelerations. You got it, Minkal. Someone just called it. Let me go back here. These are variable decelerations. And the way I remember these is they tend to make a V. They have a sharp drop off and a sharp rise. V for variable. And variable decelerations tend to indicate, yep, we've got some cord prolapse. We've got some cord compression. And when that's going on, we are dealing with a medical emergency, because what's going on with a prolapse cord? Well, basically, the umbilical cord slips through that cervix and into the vagina after the rupture of membranes, but before that baby's head descends into the birth canal. And basically, during the delivery, the prolapse cord becomes compressed by the presenting part of the fetus, usually the head, and that can completely cut off blood and oxygen to the fetus. So as you can imagine, this is a really big medical emergency. If that oxygen doesn't go get to the fetus, they're going to become acidotic and they can actually die. So what is this going to look like on assessment? Well, absolutely, we're going to see that cord potentially protruding through the vagina. And if it's already protruding through the vagina, it's pretty obvious visually. It's this glistening blue glob of tissue. It does not look like it's supposed to be there. But when this happened to me, when I caught this once on exam, I was doing a cervical exam and I felt something squishy in the vagina that didn't feel like it was supposed to be there. And as I kept my fingers in there, it was pulsing. And that's a sign, oh crap, we're dealing with a prolapse cord here. And actually, a lot of times, especially if the mother doesn't have an epidural, she's going to feel something in her vagina or between her legs that doesn't feel right. So what should we do for this? What intervention should we employ for someone who has a cord prolapse? There are very specific things we want to do here. That's the big one. Minkal, very good. Yes, Mandeep, excellent. Yep, we want that knee to chest position. This is probably going to necessitate, and probably it is, it's going to necessitate a C-section, absolutely. And oxygen, very, very good. You guys are doing great with this one. Exactly. One of the very first things we're going to do is we're going to elevate that baby's head off of the cord, because if that baby's head is on the cord, it's cutting off oxygen. It's a medical emergency. And we're not just going to lift it and then let it go. No, you need to lift it and hold it up, and you need to scream for help. This is a medical emergency. This is the situation where you go, room 202, I need help now. You want people running, because as soon as you get help, you want to reposition that patient into the knee to chest position. That's going to open up the pelvis so you can lift that head up a little bit more easily. And you're also going to use Trendelenburg to allow gravity to shift that baby off the cord. Next, you're going to administer high flow oxygen to the mother, because if you give oxygen to the mother, more oxygen is going to get to the fetus. And finally, you're going to wrap that cord in a sterile moist towel to limit that evaporative heat and moisture loss. But remember, you never, ever, ever attempt to push a cord back in. These are very delicate, friable structures. If you try to shove that back in, you could cause it to rupture, and that could cause a full-blown hemorrhage. Really, this is going to necessitate, just like you guys said, an emergency C-section delivery. So let's learn a little bit about these. These are basically deliveries where the baby, delivery of the baby is completed by making a surgical incision into the mother's abdomen and uterus. And while this can be scheduled in advance, this is often done in response to an unforeseen complication like a cord prolapse. But there are a lot of things that will necessitate a C-section: multiples, twins, triplets. Typically, it's not very likely that they're all going to be head down and pointing towards the vaginal opening. So sometimes it's just not safe to deliver them vaginally. Certainly, if you have a macrosomic, a really big baby, sometimes you have to deliver them via C-section. If someone has a prior C-section or other uterine conditions, it's usually safer to do another C-section. If the baby is malpositioned, if they're breech or bottom first, or transverse in that sideways position, we're going to do a C-section. Absolutely, if the placenta is covering that cervix, we have to do a C-section. And finally, if there's a fibroid or a large obstruction blocking the way, the pathway for the baby to get out vaginally, we need to do a C-section. And what you want to remember is this is a major surgery. It's going to require longer recovery times, and therefore it really should only be done for medical reasons. More and more in practice, I was having a lot of patients who were requesting it just because they were like, oh, I don't want to deal with a vaginal delivery. Can I just do a C-section? No, we're not going to do it just because you feel like it. It causes quite a few extra complications and risks. We don't want to take those risks if we don't have to. But as of 2020, almost 32% of pregnancies were delivered by C-section. And again, it comes with a lot of issues. Not only does it prolong recovery time, it increases the risk for infection, it increases blood loss, and increases the risk for blood clots. It also tends to make breastfeeding more challenging because it delays when it starts. So Mrs. Smithton, she's post C-section. She had her baby delivered okay, and the baby's 8 pounds and 6 ounces. At 1 and 5 minutes, the APGAR scores were obtained, and at 1 minute she had a score, or her baby had a score of 7. At 5 minutes, there was a score of 9. Right off the bat, what do you guys think of those scores? Are those acceptable, or are those not so good? What do you guys think? Put those in the question area for me. Good. Exactly, Mandeep. Yeah, really 7 or above, pretty darn good. It's improving though, so that's definitely a reassuring sign. I agree. What do you guys remember to be the highest score you can get on an APGAR? What's that top perfect score? This question can definitely come up on the NCLEX. Yeah, the very best score you can get is a 10 out of 10. Exactly. Really, 7 or above is good. That's acceptable, but 10 is perfect. And the APGAR score is actually named after a woman. Her name is Virginia APGAR, and her last name nicely spells out or is a mnemonic for the different indicators that we measure. Like I said, 10 is the best score you can possibly get, but it's also very unusual to get a 10, especially at that 1 minute mark, because most babies are going to have a little bit of acrocyanosis. They're going to have a nice pink body, but their hands and feet are going to be a little blue. That's very, very normal initially after delivery, and that should resolve pretty quickly after that. Also, we're looking at pulse. That should be over 100. Grimace is basically the response to stimulation. We want that to be prompt. We want an immediate response. We want a nice active mobile baby. And of course, we want good respirations. We want a strong, vigorous wah. That tells us that they're breathing well and they're not likely to be having any respiratory distress. All right, well, client update. 30 minutes post C-section, the nurse goes to assess Mrs. Smithton. Upon entering the room, she notices Mrs. Smithton's heart rate is up and her blood pressure is down. The nurse goes to palpate the fundus and she notices that the fundus is boggy. Mrs. Smithton states, "I feel like the bed sheets are all wet." We pull back the sheets and the nurse sees blood pooling under Mrs. Smithton. What do you guys think is going on with Mrs. Smithton right now? This doesn't seem right. What do you guys think? There you guys go. I see your answers in that question area. Yep, there's bleeding for sure, but what kind of bleeding is it? A couple of you guys got it right in the question area. It's a very specific type of bleeding that they like to ask about on the NCLEX. It's a hemorrhage, exactly. And we're in the postpartum period. So, yeah, you got it. It's a postpartum hemorrhage. And those are pretty scary when they happen because we're talking full-on hemorrhage, gushing blood oftentimes. So what is a postpartum hemorrhage assessment going to look like? How do we know someone is about to start hemorrhaging or at a high risk for hemorrhaging? Well, absolutely. If they have a boggy uterus, this is a uterus that's not contracting down to clamp down on those blood vessels. Remember, after the baby is delivered, the placenta is delivered, and the placenta leaves these bleeding vessels behind. The job of the uterus is to contract down on those bleeding vessels to stop them from bleeding. But if the uterus is being lazy, if it's boggy, they're not going to clamp down on those vessels. And with time, that's going to lead to hemorrhaging. So it's going to feel soft and it's going to be elevated above the umbilicus. We're, of course, also going to see blood loss. Most postpartum hemorrhage clients are actually saturating a pad every 15 minutes. And we're not talking about some little over-the-counter pad, nice and thin. No, we're talking about postpartum pads. These are thick, long, wide pads. And if you're saturating one of those in 15 minutes, you are losing a lot of blood. And again, if you pull back the sheets and you see your client is sitting in a puddle of blood, I can pretty much guarantee they're hemorrhaging. Also, if you try to stand that client up for the first time and there's just a big gush of blood onto the floor, they're hemorrhaging. This is not a good thing. You also want to look for signs of shock, and our patient was starting to have some of these. Remember, this large amount of blood loss can lead to hypovolemia. That can cause decreased levels of consciousness. Your patient might be pale and diaphoretic, and definitely they can be hypotensive and tachycardic. If you're seeing that, you should be alarmed. So, what intervention should we be preparing for here? That's a big one. I like seeing that. Oh, Michelle, I've seen many patients hemorrhaging. It is scary when it happens. I was rounding on one of my postpartum patients. One of my jobs when I was a nurse practitioner is I would round on postpartum patients and get them ready to go home. I went to do a fundal check and I pulled back the sheets, and guess what? There was a huge pool of blood. When I looked back up at my patient, she was pale, sweaty, she was shaking. She mentioned, I just don't feel good. And I'm like, yeah, I know. And I immediately called for help. I screamed for help. I had someone call the provider. And while I was waiting for help, I did that very first thing you guys mentioned, started fundally massaging and also getting a set of vitals on my patient because I was worried she was going into shock. It was definitely a scary, scary thing. And it's not the first time that it's happened. And I love a lot of these answers. Yeah, we're going to do fundal massage. We're going to administer fluids. Absolutely, we might use a little oxytocin. We might give some blood products. Absolutely. These are all very, very important. And we're going to massage hard. I like that you put that second word in there. We're not going to be super nice and gentle. We don't have that luxury. You've got to massage hard to get that uterus to contract down to that nice ball of muscle. So you guys hit the nail on the head. We need to do fundal massage and hard. So we need to warn our mother, hey, I promise I'm not trying to be mean to you, but I need to press on your uterus hard because your uterus isn't doing its job. I need to massage to help that uterus contract down on those bleeding vessels to stop you from hemorrhaging out. And you're not just going to do it once. You're going to do it every 15 minutes at a minimum. Typically, if there's an active hemorrhage, you're just continuously massaging until that bleeding slows down. Of course, we're also going to estimate the blood loss, and we're not going to just guess. Now, I'll admit, guys, back in the day when I started out as a nurse, pretty much it was just estimating. It was essentially guessing. We'd look at the pad and kind of heft it, say, oh, I think my patient lost 200 cc's of blood. As you can imagine, that was not accurate at all. We've stopped doing that, and now we actually weigh our pads, and essentially 1 gram is equal to 1 milliliter of blood loss, so we can accurately determine how much they're losing. We're also going to monitor their hemoglobin and hematocrit, and again, we're not just going to do that once and be like, oh, I guess it's fine. Yeah, we can move on now. No, we're getting serial H&Hs because these will drop like a rock. They drop really, really fast if someone's actively hemorrhaging, and you need to know where you're at. Now, believe it or not, we don't use these blood products until things get pretty severe. At least in the hospital I worked in, typically, unless the patient was symptomatic, we would not perfuse or transfuse blood until the patient's hemoglobin was less than 7. Most people, if the hemoglobin was above 7, tolerate it just fine and bounce back really quickly as long as we can stop the bleeding. But 7 or below, or if the patient is symptomatic, if they're feeling really cold, if they're dizzy, if the room is spinning, then we're also going to transfuse before that. And typically, I always order 2 units of packed red blood cells to replace that blood that they're losing. We might also use some other medications. One of those is oxytocin, and we're going to talk about that in just a minute on the next slide. But basically, oxytocin is an oxytonic. We use that during labor to induce contractions, but it also helps the uterus contract down after delivery if someone is having a hemorrhage. Now, I just got a very interesting question. Someone just said, hey, is nipple stimulation and breastfeeding accepted? Not as a way to resolve a postpartum hemorrhage. You're right. Nipple stimulation will cause the body to release Pitocin, which is an oxytonic. And actually, a lot of people, when they want to go into labor, if they're at the end of their pregnancy and they're like, come on, I just want this to end, you can do nipple stimulation, and it potentially can speed up the labor process. But we would not use it as a way to manage a postpartum hemorrhage. We want to know how much Pitocin or oxytocin we're giving, and we want to use it aggressively. Nipple stimulation isn't going to give us enough of that hormone. We might also use something called methylergonovine, also known as methergine. And basically, this is a group of drugs called ergot alkaloids, and it also affects those smooth muscles of the woman's uterus. So it helps with contractions, and it helps that uterus to contract down. Now, methylergonovine is not used to induce labor. Oxytocin is. Methergine or methylergonovine isn't used to induce labor. Instead, sometimes we use it to help deliver the placenta, also known as the afterbirth. If that placenta is stuck, if it's not coming out, methylergonovine will help that be delivered. But like I said, we want to talk a little bit about oxytocin. Oxytocin is a hormone that we use for induction of labor. And like I said, it's also used for postpartum hemorrhage. And this is going to work by stimulating those uterine smooth muscles, causing it to contract down. So if someone's getting this, especially in labor, we need to monitor the contractions. And if we're making the contractions stronger, we also need to monitor our fetus because they may or may not tolerate that. And we need to warn our patient, hey, we're going to speed these contractions up. We're going to make them stronger. So typically that's going to make things more painful. And of course, we also need to monitor our vitals, and also potassium is something we should monitor. Now, when you're giving when you're giving oxytocin, you want to give it via IV as a piggyback infusion, because you need to make sure you're accurately controlling how much and how fast it's being infused. And you always want to give this on a secondary line. That way, if the patient is suddenly, or the fetus is in distress, you can really quickly stop that oxytocin and just run the fluids on the main line if that happens. So remember, oxytocin is always given IV as a piggyback. And after oxytocin is initiated, Mrs. Smithton is stabilized. So Mrs. Smithton had a rough go of it, but luckily she came out well on the other side, and now her and her newborn baby are doing just fine. So thank you so much for joining me for that case study. Last thing I quick want to show you guys, just because we tend to get a lot of questions about this, if you're looking for, again, more help preparing for the NCLEX, and if you feel like you're someone who doesn't necessarily do well just self-studying, if you need a little bit more structure, we have something called Intense Prep. This is something that I call NCLEX Boot Camp. It really is a very intensive program that takes place over 6 weeks, and you're paired with a tutor. I'm one of those tutors that runs some of the classes that guides you through the process. You get access to live lectures. You also get access to 2 small groups a week. So you get a lot of bang for your buck with this program. So just something to look into. If you're interested, definitely look at this QR code. Our next start group is already on October 30th if you're interested in joining. But I just have to say thank you so much to all of you who joined today. I know there's a lot of review programs out of there to choose from, but we really pride ourselves on, being committed to what's best for you knowledge-wise, and we want to help you learn and feel more confident about this material. So I really appreciate you spending your time with me today. It's been a pleasure. Thanks so much for being as interactive as you were. I can tell you guys have been studying this subject, and I certainly hope you guys feel more confident about this subject after today. All right. Thank you so much, guys. I hope to see all of you again soon, and I hope you have a wonderful rest of your day. Thanks, Minkal. Good. Good. You guys learned a lot. That's what I like to hear. All right. Thanks again, guys.